right, so I think most everybody is kind of on their way back, or at least getting close to it, so we'll go ahead and get started. I'm Laravia. I work with most of the other guys up here, Steve and Mark, and everybody else that's been up here in front of me before me. It's good to be back. Thanks for having us back again. We always enjoy doing this. So they told me, they said, Lee, we want you to give a lecture. I was like, okay. Well, they left out the part that it was going to be on sepsis over lunch and for an hour. So, we'll just go ahead and kind of dive right into it. First, kind of the obligatory things, no conflicts and nothing to disclose. You can't have a lecture without having a bunch of objectives, so we're going to talk about some facts and figures first, a little bit of history of kind of, how we got to the point of where we are today and kind of what got us here. Some definitions, of course. There's all these definitions floating around, sepsis 1, sepsis 2, sepsis 3, all these things. Some key components of those things and of the Surviving Sepsis campaign. And also CMS we're going to discuss, as you can tell, favorite there. Some literature kind of then and now, and some key stuff that we're actually focusing on that are driving some of the definitions we have today. And then we're going to talk about some stuff that's kind of on the horizon for us. So first of all, this is kind of audience participation, so feel free. Sepsis, how many millions do you think it might strike a year? Any takers? 500,000. Million. 1.5 million. Anybody? So we're looking at 1.5 million. You guys have the notes, so you can cheat. It's okay. So 1.5 million per year, and out of that, about 250,000 of those die from sepsis. So, in 2011, we spent about $20 billion on sepsis care, which is that's a big cost. So mortality from sepsis, and this is kind of what a lot of this lecture and a lot of the things that kind of surround sepsis focus on, is the mortality rate is huge. It's 20 to 50%, depending on, is it sepsis, septic shock, severe sepsis, which we'll talk about severe sepsis later. So that mortality has a huge range. In sepsis cases, it's a smaller number. It's only 1 to 2. Some depends on what you read. Up to 5% of hospital admissions. But about 10% of your ICU admissions are going to be for sepsis. So some numbers there for you. And then kind of hitting close to home, Georgia ranks 7th in septicemia and 29th in flu and pneumonia as leading cause of death in the country. So the thing is even after 20 plus years of a lot of research and focus on sepsis measures, it still ranks around 10 to 12 leading cause of death in the country. And the biggest part, or the even bigger thing, I think, is it's number one in cost as far as care for anything. It even outweighs the cost of caring for cardiac arrest, MIs, and stroke. So let's get a case going here. You guys can read this. 41-year-old female. She has a little MR, some early dementia. She's coming in from a nursing home. And she's already been treated with PO antibiotics for pneumonia for about 4 days. And she's reported to be a little more agitated than usual. There's her vital signs. So does she meet sepsis? So we're going to talk about two things. SIRS, everybody's heard of SIRS, right? qSOFA and SOFA, let me see some hands. Okay. It's not necessarily new, but it's been kind of glossed over a little bit in the past. So we're going to kind of check some boxes here. So SIRS, blood pressure, not quite there, right? Less than 90 systolic or less than 65 MAPs for SIRS. qSOFA, you got a check mark. And we'll talk about the criteria later. Temperature, not quite there. She doesn't have the fever, the 38. qSOFA, temperature is not even a part of qSOFA, and we'll talk about some of that later. Heart rate, 94. Yep, gets a check for SIRS. Not there for qSOFA. It's not part of the criteria for qSOFA. Respiratory rate of 23. She gets a check for SIRS and a check for qSOFA. SIRS, the respiratory rate is anything greater than 20, which is kind of on the lower end of that. And then for qSOFA, it's 22 is your respiratory rate. So she meets sepsis by actually both of those. And if you take a look at the agitation part, and we'll talk about that in a minute, you can say that maybe she's a little more agitated, maybe she even hits that with qSOFA as well. So respiratory infections, pneumonia, as we talked about before, kind of the leading cause of sepsis, but you can see the others there. Bacteremia, unspecified, abdominal sources. Oddly enough, wound, soft tissue infections, which could be another talk for another time, accounts for a pretty small portion of all these things. So all the cellulitis and abscesses that we do admit, there's a lot of podcasts and a lot of thinking out there that maybe some of these could be trial outpatient. But anyway, another talk for another time. So get into some previous definitions of sepsis. Well, I love this one. I don't know if it shows up good for you guys. This is simple. I'm a simple guy. I like simple definitions, and the Greeks nailed it. Word for rotting flesh and putrefaction. Unfortunately, CMS and everybody else wants bigger, better definitions. So in '91, the American College of Chest Physicians and the Society for Critical Care Medicine gave us actually sepsis 1 definitions, which is where we get SIRS from. And that's the 3 clinical aspects of it, and then the laboratory finding of the leukocytosis. So we operated on that for several years, about 10 years, and then in 2001, the ACCP and SCCM got back together again and gave us sepsis 2. Well, they already knew that sepsis 1 wasn't a great definition, not a lot of evidence, but it was kind of the best they could come up with at the time. And in the 10 years between 91 and 2001, nobody else had really come up with anything better. So they said, well, we'll just rinse and repeat, okay? So kind of, chugged along with there. And then in 2001, this small little study Manny Rivers did, early goal-directed therapy, was, printed up in this little tiny medical journal, New England Journal. And we've been operating on the Manny Rivers protocol, early goal-directed therapy, starting then. So for about 20 years, we've been, functioning on sepsis 1, sepsis 2, with the categories of sepsis, severe sepsis, and septic shock. And we've all been riding the early goal-directed therapy train, up until around 2014 or so. And then in 2014, a few things happened. The sepsis kind of trilogy there came along. Anybody read any of these? These kind of, some circles were read pretty well, other circles not so much. So the process trial, the ARISE trial, and the PROMISE trial. These 3 papers basically really turned our heads as far as what we were thinking about the previous kind of Manny Rivers and the old early goal-directed therapy. Now, I don't want you guys to think I'm bashing early goal-directed therapy and the Manny Rivers. It was what we had at the time, and we used it, and that's part of research and part of medicine. But these 3 trials we're going to talk about really kind of changed that. So the process trial was in 2014, and all these were in JAMA. This was the protocolized care for early, and I emphasize the early septic shock there. It's a pretty good trial. It was a multi-center randomized control trial. Had 1,300 and change as far as patients. This was all done in 31 academic tertiary EDs. So not necessarily smaller places, but tertiary places. And the primary endpoint was a good thing. It was patient outcome. So it was a 60-day in-hospital mortality. They had 3 arms to this. They had the early goal-directed kind of what we had been doing therapy, the protocol-based standard therapy, which was kind of a wishy-washy, you could do a little early goal-directed therapy if you kind of sort of thought you needed to. And then they had just usual care, and you can see kind of the breakdown of that. In the early goal-directed therapy, it was the basic Manny Rivers protocol, central line, CVPs, we're measuring central venous oxygenation, we're doing transfusions, vasoactive agents, inotropes, all those things. The protocol-based was no central lines unless you thought you needed them. No inotropes unless you thought you kind of needed them. No transfusions unless you kind of thought you needed them. And then the last one, the usual care, was just whatever the physician directed. And you can see this broke down into 92 deaths, 81 deaths, 86 deaths, but you can see the percentages over in the end. And basically this study found that there was really no improvement in 60-day mortality between any of these. So the second one came along at the same time, 2014. This was the ARISE trial. This was the Australasian Resuscitation and Septic Evaluation. This was another prospective multi-center trial with about 1,600 patients in the EDs. But this time they only did 2 arms. And the interesting thing about this study when I was looking at it was that it's called the Australasian study, which included Australia, New Zealand, Hong Kong. But then, I mean, I'm pretty good with geography, but then somehow the Finns and the Irish got in on this study, and I don't really know how, but they didn't even get their names in the title, so I'd be a little upset about that if I were them. But anyway, the primary endpoint here was 90-day all-cause mortality. And you can see here, early goal-directed therapy group basically versus the usual care group basically got more interventions. They got more IVs, more vasopressors, including dobutamine, which, you know, that's another talk for another time. I think Dan's going to talk about pressors later. They also got more transfusion. They got more everything. And you can see that the 90-day end result was basically 18.6 and 18.8 as far as mortality. So once again, no change in the outcome. And then in 2015, this one kind of, you know, it was, I guess they were doing maybe best 2 out of 3 or whatever they were doing, but this really put the nail in the coffin as far as protocol-based kind of therapy for sepsis. This was the protocolized, as you can tell, it's a UK study, management in sepsis. It was a multi-center study done in 56 EDs in the UK. And back up a little bit, the ARISE trial and the PROMISE trial were both done in community, private, academic. They were done kind of all across the board. So it kind of took away the, oh, that's just academic settings that the PROCESS trial did. These last 2 studies did kind of all-comer EDs, if you want to think about it like that. But the primary endpoint, once again, all-cause mortality at 90 days. Once again, I'm not going to read it to you. The early goal-directed therapy group got more everything, and the outcomes were still the same, so 29.5 and 29.2. So once again, no change in the outcomes there versus usual care and protocolized care. So what's the common thread in all these studies? And if you look at it, the obvious common thread is, you know, usual care, what you think or what you want to do right by or do right for the patient, and, you know, versus protocol driven things. But if you look at these, I think there's something kind of more at the core to this. And all of these studies, if you read the fine print in it, they all identified sepsis early. They all intervened on sepsis early. They all tried to manage sepsis early, not try to manage it aggressively later after they were kind of behind the 8 ball. So I think these were points that were kind of glossed over by the other stuff, but I think these are key take-home points for all 3 of these trials. So these trials got us to the Sepsis 3 definition, which if you have not seen Enter the Dragon, you should see Enter the Dragon, but now we were going to enter the Sepsis 3 here. So this group actually got together in 2014, about the time that all these other trials were going on, the Third International Consensus Group, and they gave us the Sepsis 3 definition for sepsis and septic shock. So, you know, the definition for sepsis is now a little more nuanced. It rolls off the tongue a little easier. It's a life-threatening organ dysfunction caused by a dysregulated host response. That sounds way better than, what is sepsis, sirs? So, you know, this sounds way better. And they kind of told us, you know, what to look for and kind of how to identify it. As end organ damage based on a qSOFA score, sequential organ failure assessment score. And so you would score these people, and anything equal to or greater than 2, they had a higher predictive value of mortality. And then, you know, they defined septic shock for us as a subset of sepsis, in which you have severe kind of circulatory, cellular, and metabolic derangements, and puts you at even higher risk than just sepsis alone. And the way we identified that is vasopressor use to keep your MAPs above 65 and serum lactate greater than 2. So that's changed a little bit, right? Sepsis 3 from the previous definition, we're using lactates of 4. But in my opinion, the biggest thing and the best thing they did with this was they threw away this severe sepsis category because they said it was just redundant. You know, we don't need it anymore, so they totally got away with it. So now we're just dealing with two groups, sepsis and septic shock. I can handle that. So what's a SOFA score? SOFA score, the sequential organ failure assessment score. It's a score based 0 to 4, and it's based on six systems. So respiratory, coagulation, liver, cardiovascular, CNS, and renal. And if you look at where SOFA was derived from, this score was derived out of ICU literature and ICU patients. So that's great for them, because if you look at some of these things that they're scoring you off of, respiration, if you look at it's all PaO2s. Well, that's great if I'm in the ICU, I can get an ABG. I haven't had a patient yet show up and say, here's my ABG, can you tell me what it is? So that's not very helpful for us on the front end. Coagulation, okay, platelets, it's a lab test, it's not a clinical thing that I can see or evaluate at the bedside, but it's easy to get, right? CBC gets you platelets. Liver, based on total bilirubin. Once again, not something I can see unless they have scleral icterus or something like that, but it's an easy lab test to obtain. Cardiovascular, which is pretty good. I can put a blood pressure cuff on and I can get a map, so I kind of like that one. CNS, I can give somebody a Glasgow coma score, or a coma scale score, no problem. Renal, they based it off of creatinine and urine output. Well, creatinine, once again, not a physical finding, but I can get that with an easy lab test. So this is not too hard to get, but it's a little more difficult for us to have these things on the front end early, right? We want these early based on waiting on lab tests at the back end. So they decided, well, we need to give people on the front lines something that they can score clinically and easily. So they came up with the qSOFA score, and this was validated. The qSOFA was validated back against the SOFA, and it shows that it works. So this is pretty simple. I can remember this. So hypotension with a systolic less than 100. So just remember H for that. Altered mental status, that can be with a GCS, or you can kind of, if family is telling you that they're more altered, that's your altered part, so that's the A. And then tachypnea, respiratory rate greater than 22 breaths a minute. So there's your hat. So just remember, for qSOFA, you just need 3 things. And that's the only thing you need to score somebody with the qSOFA. And anybody that gets equal to or greater than 2 of these has a greater risk of poor outcome. And this is something I want you guys to key in on. It's a greater risk of poor outcome, or a greater predictor of poor outcome, not necessarily identifying patients that have sepsis. We'll talk about it a little later. So what's the good, the bad, and the ugly over all this? Okay, so SOFA is complicated. We talked about it, derived out of ICU data. Not too helpful for us in the ED. qSOFA, though, is quick, clinical, and you can do it at the bedside. But one issue is that both SOFA and qSOFA, they're mortality predictors, not necessarily risk identifiers of who's going to have, or who has sepsis. SIRS seemed to do a little bit better at that than these did. And then the new onset versus baseline for some of your qSOFA scores, kind of hard to determine. Probably the altered mental state out of that would be the hardest one to determine out of those. And here was a big point of contention for a little while, is sepsis 3 is either still not or is in the process of being accepted, endorsed by some specialties. For a while, ACCP and ACEP did not endorse sepsis 3, and I think they finally did endorse it. But you have the Latin American Sepsis Institute, which doesn't apply to us, but they still have not accepted this as a definition for them. So we're talking about predictors. What are the best predictors for in-hospital mortality? So we have 3 papers here that came along. This Chirpek paper. Basically, they looked at NEWS, which is the National Early Warning System, the MUSE, which is the Modified Early Warning System, and qSOFA and SIRS. And they found out that the best predictors for mortality in this order were, NEWS was the best, MUSE, followed by SOFA and SIRS. So then Wraith came along in 2017 and did something similar, found that SOFA was a better predictor than qSOFA and a better predictor of SIRS for in-hospital mortality. And then the last paper was done in 2017 by Freund, and they found kind of close to that, but a little bit swapped around. qSOFA was better than SOFA and SIRS at predicting mortality, not necessarily identifying sepsis. So, you know, what's the thing here? You know, what are we giving and taking? If you put qSOFA and SIRS in the corner, qSOFA does outscore SIRS for predictor of mortality in ICU care, transfer. However, at what cost? Well, it's the sensitivity. The sensitivity of SIRS has been shown to be a lot better at identifying these people than qSOFA and SOFA. And you can see here the numbers don't lie. 93%, 73%, and 70% for SIRS, SOFA, and qSOFA. So we're going to kind of get off of the sepsis 1, 2, and 3 and kind of jump into the surviving sepsis campaign. It came out in 2016. It's long. I don't know if any of you guys have read it. Unfortunately, I had to read the whole thing from front to back. 67 pages. It's 93 statements on early management of sepsis, and there are 655 references. So, I mean, there are a lot of books that, you know, aren't that long, but so it's a lot of references. So anyway, we're going to break this down into kind of the previous SSC guidelines and the 2016 ones. I think this should project pretty well for everybody. We're going to focus over on the 2016 part of this. So sepsis definition has changed. They are now using the sepsis 3 as a life-threatening organ dysfunction with a dysregulated host response. So that's a change from 2012. And they threw out the severe sepsis category, like we said earlier. Initial resuscitation, well, that really hasn't changed very much. Everybody still getting that 30 cc's per kilo bolus in the first 3 hours. There's really no recommendation. Crystalloid of your choice, normal saline, LR, plasma light, Normasol. Anybody have those last two, the balanced solutions? Probably not. There's really no recommendation as far as either one or any of them. You can use whatever you have or want. And then they talk about albumin if a patient requires substantial amounts of fluids. This was a weak recommendation, and I personally would lean away from probably giving albumin to people. If you're having to give people that much fluid, you probably should think about pressors, because then it becomes an issue of the pump is, you know, it becomes a pump and a tank issue, and you don't want to overload that system, and you may start doing that if you start to give a bunch of albumin. So we get down into to guiding our resuscitation, talk about using dynamic resuscitative markers like the passive leg raise, which we will talk about in a minute. Keeping that MAP above 65, that is, you know, still what we're looking at doing. We're getting away, or we're not doing the protocol management anymore. And then we want to reassess. You know, go look at the patient, go check the vitals again. What's their skin look like? What's their cap refill? How's their mentation doing? And then lactate normalization. So this showed up again, but it's a weak recommendation. Unfortunately, you got to do it for CMS. So, it just is what it is. Using vasopressors, once again, we're targeting that MAP of 65. Norepi is a great first line. Epinephrine is a good second line. You don't have to worry about epinephrine. We'll talk about this in a minute with lactate and some other things messing up your levels. And just says, avoid dopamine, so which we probably should be doing. And then steroids, give steroids for refractory shock that doesn't respond to fluids or the vasopressors. Another talk for another time. There have been lots of studies, the high-press study, the adrenal study, that showed that, the outcomes, even with steroids, it's not really what we thought it was going to be. So, but it is in the recommendations. Then antibiotics. So antibiotic administration has changed a little bit between the 2012 and the 2016 surviving sepsis guidelines. We give initial broad spectrum antibiotics. The SSC recommendation is within 1 hour of sepsis identification. So a little different than before, where CMS and surviving sepsis was within 3 hours. Now we're on the clock. We're looking at about an hour for that. And they basically recommend against double coverage and Pseudomonas coverage just in general for this. And then they talk about procalcitonin, which a couple problems with that. Who even can order a procalcitonin and get it back? Really, I'd like to see a hand. Order it and get it back in a reasonable time. That would be awesome. The thing is I'm still waiting for the literature that shows me that it is what we thought it is. There are some papers that are out there that are helpful. I'm hoping more literature comes out, more studies come out about using procalcitonin. But I'm glad you can get it back. I cannot. Source control, we're probably not going to be doing that in the ED. You're probably going to have shipped them out or have sent them upstairs before you're having to do any of that. And then the ventilator, we're still using ARDSNet protocol and those type things. So we got a few things to kind of go over as far as what's new this year, or new for the new sepsis guidelines. So the passive leg raise. This is basically it's a test. It's a non-invasive test that kind of auto-administers about 300 or so cc's of volume from the lower extremities. And what this does is it's temporary. It's a reversible thing. It mimics an IV fluid bolus. So the thought behind this is that you have somebody who comes in, you want to try to see if they're going to be fluid responsive before you start giving them a bunch of fluid. So you perform this test. So does it work and is it clinically reliable? Yes, it is. The study, sensitivity and specificity are pretty good for this. Does it require special equipment to do it? Yes, it does. You either have to put an art line in, and when you perform the test, and what you do when you perform the test is basically the patient usually starts in kind of a semi-recumbent position. And then you'll lay them flat and then kick their legs up about 45 degrees and hold it for about 2 or 3 minutes. And then what you're looking for is either a change in your A-line graph, or if you have a cardiac output monitor with a lot of the bells and whistles, not the standard ones we have, but some of the other ones with I forget what it is, but it's all of the bells and whistles for the high-end cardiac output monitors. You're looking for a change in the stroke volume is what you're looking for. You can also cheat a little bit and use an ultrasound to measure the left ventricular outflow tract and do some velocity measurements there, but it gets a little time intensive, and it's not super complex, but honestly, if you're trying to manage this patient and you probably have 4 or 5 other patients and phone calls and everything else you're doing, you may or may not have time to do this with the ultrasound. But what you're looking for is an increase in stroke volume of about 10 to 15%. It's a good predictor that they will be volume responsive to whatever you give them. However, patient outcome data is kind of lacking for this. So it is part of the surviving sepsis guidelines for 2016, but it's a weak recommendation, but it is one that's there. So one of my favorite topics is love, hate, and lactate. It should be like a band name, I think, maybe love, hate, and lactate. I don't know. Sounds pretty good. It's one of these things we kind of have to go along with what CMS kind of tells us, and we'll talk about that a little more later. But some things I want to get across is elevated lactate in septic shock is not due to anaerobic metabolism, and it is not an indicator of inadequate oxygen delivery. It's not what a lactate is. Most of what lactate is a response, a beta-adrenergic driven response to the shock itself, and it may actually be beneficial to us. But lactate is also good because it still helps us identify those kind of the cryptic or kind of occult shocks that are out there. And then serial lactates should be gotten for CMS measures because you got to get paid, right? But it should not solely direct your resuscitative guides. I've seen plenty of people, and I'm sure everybody in here has, who have been given tons of fluids and basically drowned in fluid to try to clear that lactate. So you need to monitor the lactate, but don't let it be the only thing that you're focusing on. Don't ignore it all. Don't put the blinders on just for the lactate. So we get into the antibiotic part of the 2016 surviving sepsis guidelines. And I was just searching around looking for some stuff, and I saw this, and I came across this meme, and I thought it was appropriate and hilarious. But so broad spectrums are now within an hour of identifying sepsis or septic shock per the new SSC guidelines. So really, really under the gun here. How many of you guys keep, I don't know, Vanc, Zosyn, any of those things in the Pyxis in the ED? How many of you guys have that in the ED? How many of you guys have to get it from pharmacy? Okay, so we got, we got a little of both here. So getting it from pharmacy already puts you, way behind everybody else who kind of has it on hand. So what if I said, well, how about as far as the vancomycin, how about if we thought about giving it last? What do you guys say to that? Yes? No? He's crazy? So I kind of want to, prompt you to think about maybe giving Vanc last, and the reason is in the past we way underdosed the loading dose for Vanc. We were given, who used to give a gram of Vanc? Who used to give 1,500 milligrams of Vanc? Just, that's what you did for the first time loading dose. Well, if you look at the recommendation, it's 25 to 30 mg per kg. So for the standard 70 kilo patient, which I'm not sure exists anymore unless you're on the pediatric side of the emergency department, you were way underdosing these people, right? So, so that's part of it. So we have to give larger doses than we thought. Now, what if I told you the max infusion of Vanc was 10 mg per minute? All right, so you're already doing the math in your head, right? This just isn't going to happen. And this honestly isn't something that we think about. This is more of a nursing issue that, in our minds, we order the med, we order the, whatever, they mix it up, they give it. So if you look at the time it takes anywhere between 1 to 2, depending on the size of your patient, up to 3 hours to get Vanc infused. So I would tell you, if how many of you get nasty grams from the C-suite people about, hey, you didn't give antibiotics in time? Nobody? Okay, all right, there we go. Okay, I was going to say I get them all the time. It's not, I blame it on the residents. It's not my fault, it's the residents. But what I would say is, if you are getting those nasty grams, think about giving the Vanc last. Give this, and if you think about compared to Zosyn, Cefepime, Levaquin, some of the other things, the aztreonam, the extended spectrum beta-lactams, Vanc is not necessarily that broad spectrum antibiotic that we're looking for. It's the Cefepime, the Zosyn, the Unison, the other things that are going to do that. So you want to give it, but give it at the end. So let's talk about the dollar, right? We now have sepsis 1, 2, and 3 definitions out there. We have the new Surviving Sepsis Campaign guidelines that we have. The unfortunate thing is that now we've got all these things we have to think about and focus on. And CMS came out with their guidelines. Well, they beat the Sepsis 3 definition and the Surviving Sepsis Campaign. So now we've got kind of these two things we have to kind of follow or kind of think about when we're treating sepsis. So the current CMS guidelines that are out there are still using Sepsis 1 and 2 definitions, and they have severe sepsis and septic shock. Remember, we already did away, according to the new guidelines, with surviving sepsis, or with Sepsis 3. We've already done away with severe sepsis, but they are still in the CMS guidelines. So you have to know that they're there, and you also have to think about that lactate of 4 for the septic shock patients, and monitoring it. Not necessarily, you want to improve it with your treatment, but once again, I don't want you to focus on that being your sole treatment there. And then, we've got some marks to hit. We've got time 0, we got 3, and then 6 hours that we got to hit. So at third hour for CMS criteria to meet it, you got to get that second lactate. You've already gotten the time 0 lactate, hopefully. You got your second lactate. You've already given your antibiotics and your blood cultures prior to antibiotics. That is still what you want to do, blood cultures before antibiotics. And then 6 hours, we're going to repeat that lactate again. And then, you can follow the flow chart down here. Now, it is interesting that at the bottom, they do talk about bedside cardiac ultrasound and passive leg raise, which I'm a huge fan of cardiac ultrasound. But what I don't want you to do is I don't want you to put the probe on there and just look at the IVC. Okay, if you're looking at the IVC, it's only a couple more centimeters up. I want you to take a look at the heart, okay? because if the heart can't handle it, the IVC really, it's not going to do you a whole lot of good if you're pumping a lot of stuff in and you can't get it out, can't get it to where it needs. But so use the ultrasound to guide your resuscitation, definitely. So exclusion criteria for CMS and septic shock. It is a government organization, right? They had to come up with something to exclude things. Comfort care order, these people get kind of excluded from the criteria for CMS. So, if this happens, you won't get, I hate to say dinged, but you won't get dinged for it. So comfort care ordered within 3 hours of sepsis or 6 hours of shock. Patient expires within 3 hours of sepsis or 6 hours of shock. And then if they're a transfer from an outside hospital. So if these things are there, then you kind of don't have to worry about the CMS guidelines. But you still have to resuscitate the patient. You still have to do what you need to do for the patient. But I just wanted to include those there. All right, so what's coming down the pipe? How many of you guys have heard of Dr. Merrick and his research that he's been doing? He actually does a lot of research. He's an intensivist, puts a lot of good papers out there. So did he crack the code in 2016 with this cocktail of vitamin C, hydrocortisone, and thiamine? They did a study, 94 patients. There was no randomization. It was just a study there in-house. They basically gave them a cocktail that you see here, vitamin C, hydrocortisone, and thiamine, while they were in the ICU. And the primary outcome was the hospital survival. Secondary outcomes were those: did they have to use vasopressors? How much? How often? Did they have to do dialysis on severe acute kidney injuries? What was the ICU length of stay? They checked procalcitonin changes, and they also checked rechecked the SOFA score over 72 hours. And what they found out is the treatment group did way better. I mean, way better in everything except for the ICU length of stay, which I thought was kind of interesting, than the control group, the group that got nothing. So, this seems awesome, great, right? I mean, that these three things. I mean, 2 vitamins and something the body already produces, cortisone, that can actually, maybe kill sepsis. Well, I mean, I don't know that this is ready for prime time yet. It seems great. I just think there needs to be some more research done. And I think this was a great kind of primer prompter to put the hypothesis out there. Can this help in sepsis? And I'm not going to go into all the details, but if you look at the paper and a lot of the reasoning behind it, it talks about the vitamin C and the thiamine being factors and cofactors driving a lot of the kind of beta adrenergic surge and a lot of the other processes that could help with sepsis, cellular support, and things like that. But it's not quite ready quite yet. All right, so about to wrap this up. I just want to leave you with a few final things. Let you guys read this. Anybody can tell me who said it or when they said it. Just blurt it out. Who? All right, I got a vote for Osler. That is right. Dr. Osler said this in 1896. And if you read this, I mean, it seems very much what we're doing today. We have all this stuff going on, treating this terrible entity, but nothing really seems to stand out very much, and we're just kind of following along. But it is what we have. It is where we are. But hopefully in the future, we'll be able to take sepsis kind of head on. And I think we've actually come a long way. I really do, from where we were 20 years ago, and even before 20 years ago. So some take-home points. I think early recognition, early identification, and early management is where we need to be with sepsis. We have to do all the other things. We have to give the fluids and everything, but we need to identify it early. qSOFA and SIRS. qSOFA is in, SIRS is out, but I don't want you to think of it as black and white, 0, 1, yes and no. Use qSOFA, use SIRS, whatever you do, but identify the sepsis. That's the thing that I want you guys to take home, is you got to identify the sepsis. No score is better than the other. I mean, we've already shown that. qSOFA is great at predicting mortality. SIRS is better at identifying those people that are at risk of sepsis. It's a spectrum of disease, and it's hard to pin down and kind of put in a corner. And if the patient looks sick, you don't need a score to tell you that, right? I would tell you think about giving your other antibiotics before you give the bank, just because it takes so long to infuse, and the other antibiotics are the broader spectrum that you need to be giving anyway. We've got a lot of definitions. We have a new sepsis or surviving sepsis guideline, and we have the CMS sepsis measures that are out there. They all differ. You have to follow CMS in order for the hospital to get paid, you to get paid, you to not get emails from the C-suite people that you want to tell them to come down and manage the patient if they want to send you all those emails all the time. So we have all these different things we kind of have to follow and do. And at the end of the day, sepsis is not a one-size-treatment-fits-all plan. It is not that type of deal. You can't give. You kind of have to say and kind of have to do some things, some creative, creative number crunching to give that 30 cc's per kilo bolus sometimes to that end-stage renal patient and CHFer who probably doesn't necessarily need all of that, but you still have to, make sure that you do check the boxes for it. But it is not a one-size-treats-all plan. And this is my favorite thing, and I got this from the ASEP Now article in ASEP Now when I was researching this, is guidelines they're a counselor, they're not a jailer, okay? Guidelines give us a framework, kind of a scaffolding to direct kind of where we need to go, but they don't really trump your clinical gestalt and what you're doing at the bedside. So you got to have guidelines, but you also have to, use your head at the end of the day. So there's some references there. I won't bore you with all those. And it's what it feels like most every day in the ER, right? But we love it. So, any questions or anything?
So, what do you do as far as volume for your renal failure folks or your folks with CHF?
So I will start out with if it's a young people, whatever, no issues, no problems. I'll give them a liter all day. I'll give them 2 liters all day. The CHF patients, at the end of the day, and this is what I tell the residents, CHF is, there's diastolic and systolic. The systolic heart failure is what we really care about when we're given large amounts of fluid. The diastolic heart failure folks can typically handle a liter, liter and a half. Maybe not over an hour, but they can typically handle that a lot better. The end-stage renal people, I tell you to give them 500 cc's. Use that ultrasound. Do you have ultrasound, or can you? So I would tell you. So my protocol for anybody that I think comes in with sepsis, I'm doing however you want to look at it, the HIMAT protocol that Malmet does up in Maryland, or the RUSH protocol that's been kind of shown and put in papers, whatever you want to call your undifferentiated sepsis ultrasound algorithm, that's what I'm doing when they roll in the door. So I know what their output is. I know, how dry, how volume deplete they may or may not be. So I'm able to, I think, give those people fluids a little better than not using the ultrasound. So what I would tell you is without the ultrasound, I'd probably give them 500 and see how they do. You have to recheck the vital, kind of what they were talking, or part of the CMS stuff. If you have ultrasound, I would tell you to use that. You're going to be able to hit your mark a whole lot better as far as fluid resuscitation, especially with those patients. Does that answer your question, or a little bit? I would tell you to give them 500. If you don't have anything except patient's hypotensive and you don't think it's volume overload, I'd give them the 500. And then you kind of have to go from there. Hopefully in 3 hours you can have them out the door, and then you don't have to worry about the CMS part of that. Anything? Yeah.
So not really what clinical take-home per se, but out of curiosity, in the recent studies that show the SOFA was better than qSOFA and vice versa, do you know if the patient population varied in any distinguishable way?
Yeah, I don't. I did not look at those very hard, honestly, when I was putting this together. I was basically the Muse and the News score are a little more triage scores for whatever a patient kind of presents with than the SOFA and the qSOFA. So you are looking at kind of different, patient populations as far as that goes. But I didn't dig into the roots of that paper. So I can't answer that question, but I can tell you that the Muse and News are more overall general complaint scores than the qSOFA and SOFA. Does that help at all? Anything else? All right, enjoy the rest of your lunch, or 2 minutes left.